Welcome to the Dr. Lexi Show, where I take pregnancy topics and break them down as best I can. And this is our first episode of the Dr. Lexi Show podcast. And we'll have guests here and there. And my goal is to break down topics to help you advocate for a happy and healthy pregnancy. So I am Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And today we are with Jami Savage Gray. And we are going to be talking about all things pregnancy, some IVF, lots of different random topics just to chit chat about today. So welcome to the show, Jami.
Thank you. Glad to be here.
Thanks. Well, I wanted to start out a little bit first and just ask you to maybe share with us who you are, what you do, and kind of maybe some topics that you're comfortable and want to talk about today surrounding pregnancy.
Sure. Again, thanks for having me. I'm Jami Savage Gray. I am a commercial real estate broker, so I specialize in office leasing. I can talk about many subjects in the last 3 years, anything from breast cancer to IVF to AMA, and then we're pregnant. So
congratulations.
Thank you. It's been a long road.
Yeah. Well, so before we get started on all the topics, I have surprise questions. Okay. And nobody knows these questions for anyone listening. So these are all, every guest is going to get the same few questions. They're not hard questions. They're kind of more just like, one of my big things is trying to, figuring out what we don't know. Cause that big saying, like, you don't know what you don't know.
Right.
Yeah. But what if you knew what you didn't know? Like,
Touché.
Wouldn't that be fun?
Yes.
So the first 10 questions are just answers you would like. And then following that, we have some true false questions.
Okay.
So, all right. Are you ready?
Yeah.
And by the way, guys, Jami has no idea what these questions are. No one does. These are all surprise questions. All right. Question number 1. What does the abbreviation OBGYN stand for?
I don't know.
Do you have an OBGYN?
I do.
Okay, perfect.
I have lots of those. I have lots of doctors with abbreviations.
Okay. And there are a lot of abbreviations in our world. Okay. Question number 2. What do the letters MFM stand for?
This is what you are.
This is what I do. Yeah.
Yeah. I use this all the time. I think it's maternal fertility something.
There you go.
Yeah.
Okay. Question number 3. How does a provider come up with your due date when you're pregnant? So do you know your due date right now?
I do.
Okay. Do you know how they came up with that?
Mine's cheating because it was an embryo transfer.
Okay. But that's actually a good answer because that's how they came up with it.
Well, there you go.
That's the answer.
Yeah,
so it's a
perfect.
correct answer. Okay. Question number 4. When is a pregnancy considered term?
Term. So I do know that forever it took forever for it to become a fetus. I do know that. So is that considered term? No. I have no idea.
That's okay. That's why we're going through these. This is fantastic. Okay. Question number 5. What is a normal fetal heart rate?
I don't know what normal is, but I know my baby boy's been between 153 and 160 the whole time.
Okay.
And boys have faster heartbeats than girls. Yes?
Oh. I don't know if that's
been told.
Well, and who told you that?
My OBGYN.
Okay. So then somewhere along the road, I put, there's probably an article on that. Okay. But that is a normal fetal heart rate for sure, which is great. Question number 6. What is antenatal testing or fetal well-being testing?
Oh, we've been doing so much testing. So we just had our anatomy scan last week. Prior to that, I think 4 weeks prior to that was that testing. And I think that was to test the fluid in my sac.
Okay. Question number 7. How does an ultrasound estimate the weight of a fetus? So you had your anatomy scan not long ago. Did they tell you the weight?
14.5 ounces.
14.5 ounces. Do you know how they came up with that weight?
No, actually.
Okay. Question number 8. What makes up amniotic fluid?
I don't know.
Okay. These are great questions though, right? Don't you think? They're right? Okay. Question number 9. Who should be offered Down syndrome screening in a pregnancy?
Typically, I know if you're 35 or older, right? So if you're an AMA case, but one could probably argue everybody should be offered.
Okay. And question number 10, what is considered a normal length of a cervix during pregnancy?
Interesting enough, I just went to my anatomy scan and I was like, what are we seeing? Because it was like an hour long. And she was like, your cervix is good. I did not lean in and say, what should it be? All I know is my cervix is good. That's all I know.
Okay. I love it. So some of these questions we're actually going to go through, but the reason I bring up these questions too, almost all right now, if not now, and in the future are addressed on my YouTube channel. So if you're like, I really would like to know how they do a weight of the baby, I have a whole YouTube explaining exactly how they come up with it. Okay. Because like, if you're there and you're like, oh, my baby's 2 pounds, 2 ounces, is that normal? How did you get that? What are all the measurements? Like questions to ask so that you can kind of be involved and kind of understand more. Okay, this is great. So I'm not really sure the best way to do this, but do you want to know the answer to these questions before we move on? Okay. All right. Let's see. Question number 1, what does the abbreviation OBGYN mean? Obstetrician and gynecologist. Okay. So obstetrician, gynecologist. So they are an OBGYN, we call them, right? Some people only practice OB or GYN.
See, that's why I get confused.
Super confusing.
Because I'm like, why do some of us just say, oh, I have an OB, and other people say, I have an OBGYN? I'm like, yeah, I have no idea.
So the base answer to that probably would be all of them went through training to be an OBGYN. Okay. Right? And then some of them practice both OB and GYN, and then some start to kind of just do one or the other.
So they pick one, typically.
Well, usually you do both of them all the time, and then you kind of phase out of one. Okay. Most people do obstetrics and gynecology, and then they're like, I don't want to deliver babies anymore because I'm waking up at 2 a.m. And then they get rid of the obstetrical part, and then they just continue with the gynecologic part, like pap smears and annual exams, and maybe some gynecologic surgeries and stuff like that. Okay. I think in the future they're going to split it up where you do either OB or GYN. I don't know, because there's so much to do in each category alone, right? But that's a good question when you find an OB-GYN. And some people say OB-GYN, OB-GYN. So I'm trying to spell it OB-GYN to not, because everyone in different parts of the US says it differently. It's a good question when you see someone to say, how much do you do as far as OB versus GYN?
Interesting.
Right? Because if you have an OB-GYN that does 90% GYN and they only deliver babies 10% of the time, and you're going there just for your pregnancy,
you might want to know that.
Good
to know.
Yeah. And same for people like if you're not having kids and you're like, oh, I just need to make sure to get my pap smears, and oh, wait, I have an ovary that ruptured in the middle of my day, which this happened to me. And I'm like, it's got to come out. It's ruptured. It's hemorrhaging into my abdomen, all this kind of like nasty stuff. And you're like, no, this is not fun. I want the person that does GYN surgery all the time and not the person delivering babies on a daily basis, because I want the good laparoscopic surgeon.
That makes sense.
Yeah. Okay. So MFM, maternal fetal medicine.
Yes. Okay.
Yep.
Yes.
How do they come up with the due date? You give them, IVF, right? So if you do IVF, you give them your this is when my transfer was. And then if not, then you say, here's my last menstrual period. Then they do an ultrasound early on. They compare the two and see if they jive. And that's how they get the due date. So not rock. I mean, it's not so scientific. It's just kind of like, I don't want to say guesswork, but it still seems like it's guesswork, right? Question number 4. When is a pregnancy considered term? 37 weeks and beyond. It's term. Okay. And it's kind of important. So when you move forward and you're like, oh, my prior delivery was term or preterm, it helps your OB-GYN decide what to do for a future pregnancy. Okay. But a lot of people don't know the terminology or the term. Yeah. Right. So when I ask a patient, was your last delivery term or preterm, they don't know the difference. And so if it's prior to 37 weeks, it's considered preterm. If it's 37 weeks or after, it's considered term. Okay. And then they break it down into early term, full term, all this kind of stuff. What is a normal fetal heart rate? Typically between 110 to 160. Okay. However, the earlier you are, the higher the heart rate is. So really, really early fetus could have a heart rate in the 170s, 180s even. And the heart rate for a fetus slows down as they get older, which is kind of cool too.
Yeah.
So what is antenatal testing or fetal well-being testing? That's going to be when people get to be in their 3rd trimester and they're checking on how the baby's doing to hopefully decrease any risks or concerns of stillbirth. So later in the pregnancy, you and your doctor will talk about fetal well-being testing or antenatal testing at some point. So that's 3rd trimester typically. What does an ultrasound estimate, or how does the ultrasound estimate the fetal weight of a baby? They actually measure the arm bone, the leg bone, around the belly, around the head, and take all those measurements, put them into a formula in this computer and the calculator type thing, and then it spits out a number.
Wow.
Yeah, I know. One day I think it'll be different though, because they're just having to do 2D measurements and giving you a volume, right?
Yeah.
It's crazy. What makes up amniotic fluid? Baby pee.
Perfect.
Yep. It's the P. Who should be offered Down syndrome screening? Everybody.
Yeah.
You're correct.
Yeah.
And then what is considered a normal length of a cervix in pregnancy? Typically 2.5 centimeters or above. We like it to be 3.0 centimeters or above. But yeah, I love that yours was great.
I guess mine is good.
Yeah.
It's good to get good news.
It's good to get good news.
Yes.
All right. These are true, false questions. There are 10 of them. You just answer true or false.
Okay.
Question number 1. A fetus can have hair while in the womb.
True.
Question number 2. A fetus can hear.
True.
Question number 3. If a pregnant individual eats sugar, this will wake the fetus up if it's sleepy,
True.
like if you don't feel the baby move. Question number 4. Everyone should be screened for diabetes when pregnant.
True.
Question number 5. Everyone should be screened for thyroid disorder when pregnant. Question number 6. Everyone with 2 prior cesareans has to have a third C-section.
This is a good one. I'm going to go with true.
Okay. Question number 7. Twins that are the same gender are always considered identical.
False.
Question number 8. No cheese is safe to eat in pregnancy.
No cheese is safe. That's false.
Question number 9. Someone trying to get pregnant should start taking folic acid before they get pregnant.
Oh, man. I didn't have a normal one, so I'm going to say false, even though I had tons of vitamins.
Question number 10. Baby aspirin is an over-the-counter medicine that could prevent a certain type of high blood pressure during pregnancy. Yes. Okay. So the hair thing, yes, they totally can have hair.
He has his little, he does right now.
Aw,
yeah.
So cute.
It's all over his body.
All over his
I forgot
body.
what it's called, but it's all over his body.
Question number 2. For the fetus can hear at 25 weeks, they start to basically feel the vibrations. And so it's not technically hearing kind of, but the vibrations get them moving, which is why when people say they don't feel their baby move, we can put a little like mechanism that like vibrates a little bit and the babies will sometimes wiggle and move because they'll sense it. The sugar thing is false. Sugar actually makes babies sleepy.
Really?
Yep. So when people don't feel the babies move, they should do like cold water or like a little vibration.
I've been
on the
loving
belly.
Cold milk.
Cold.
He'll move.
There you go.
Like I drink cold milk, I sit down and he'll start moving.
There you go.
Yeah.
See?
Yeah. It's crazy.
It's going to have strong bones.
Yes.
Strong bones. The thyroid is actually false.
So I'm on it.
Oh, so you're a different, right?
Yeah.
So when they did IVF stuff for you and we're doing all those tests, they screened you then, right?
And what's so interesting, I mean, as you know, you learn so much about your body as you go through this stuff, but I was fine when they did all the screening. And then when my transfer stuck and I got through like the 14-day wait, they called me and said, your thyroid's high. Like we need to get you on thyroid medication, which I started. And then I just went back to my doctor 4 weeks ago and they upped it. And so she said, it might just be something that I think I was teetering anyway, because in college I was kind of taking it, but I didn't feel different. So they took me off of it. And so she's like, it might be something you're always on. Like thyroid disease is a legit thing for women. And she's like, it just might be something we'll lower your dose after, but you might stay on it forever.
Yeah. And most people, all people that are going through reproductive endocrinology and like talking about infertility, they're screened for thyroid issues because like you said, it's pretty common to see. For people that when they are pregnant, we're not meant to screen them just willy-nilly because the thyroid does change during pregnancy. So you can get weird labs that end up looking abnormal when really they're just normal physiologic changes of pregnancy. But for you, it's very common when people start a thyroid medicine, they have to increase it during pregnancy. Because of these changes that the thyroid undergoes. So okay.
Yeah. So I'm on thyroid medication.
And thyroid medication is very safe to take in pregnancy.
Yes.
People get worried about it sometimes, I think. And if people have hypothyroidism, which is when the TSH is high, which sounds backwards, right? Like the TSH is high, but you call it low, right? That medicine is super, super safe. And I actually do have a module on that on the website too that goes through all of it, because if you're well controlled on a thyroid medicine for hypothyroidism, there are really no increased risks for your pregnancy based on just the thyroid part. Which is awesome.
Yeah. And it made me feel, because the first thing, I mean, when you're getting pregnant, you've tried for so long, this hard, the minute they have a flag, you're like, oh, well, if I start taking it now, did it hurt him prior? You know, you're like, I feel like I'm playing catch up but I should listen to your module.
Yes, you should. Very educational. Let's see, the C-sections, they do not have to have a third C-section. It used to be that way. And then they found that if you've had 2 C-sections, you can still try to do what we call a trial of labor after cesarean, TOLAC. We abbreviate everything in the medical world, right? So
what if you've had 1?
If you've had 1, you still have the opportunity to do a trial of labor. That's a general statement. It depends on.
That's so rare.
The reason I think that I know it's becoming more rare too, is because for individuals to do that trial of labor, like once they've had a C-section and trying to have the next one vaginally, the hospitals where they deliver typically have to have some type of a protocol to allow an individual to do a trial of labor, meaning it's different for every hospital, but they usually have to have an OB/GYN that's within X number of minutes of the hospital or truly in the hospital, an anesthesiologist that's available in the hospital for OB issues. And a lot of smaller hospitals don't have the resources to offer individuals a trial of labor because they don't have whatever protocol their hospital says is a safety protocol to allow someone to do a trial of labor.
Got it.
So even though it's an opportunity for them, they might not live in a location where it would be allowed or it would be considered safe for them.
Okay.
So twins, same gender, not always identical. You're correct that is false. They can be identical. They cannot be like the movie Twins. Remember with Danny DeVito, right? Like, which is, I just think a hilarious movie, old movie. No cheese is safe. That's false because you can eat certain cheeses. If they're pasteurized, they're considered safe. If they're not pasteurized, not safe because of listeria, which is the bacteria.
I'm missing my blue cheese.
I know.
I will tell you that.
I know. It's got to be hard, right? Like if you have something that you just love to eat and all of a sudden you're like,
taken.
It is. It's taken, right? It's not fair.
Well, what's so weird about the IVF thing too is you're just like, I'm never going to complain. So I'm like, I'm not going to complain. I can't have blue cheese. I'm just very happy to be here and be pregnant. So not going to complain.
I like that outlook. Yeah. That makes sense because you did all this to get there and now you're going to do everything to make it the best you can.
Exactly.
Right? I love that. And then as far as folic acid, everybody should be taking folic acid before they get pregnant. And the information on it's super confusing because folate and folic acid sounds confusing, right? Folate is actually what you get in the natural foods. And folic acid is if it's supplemented, like in a rice and a bread, it's supplemented with folic acid. But if you eat a vegetable that naturally has it, it's folate. Okay. So the terms are different, but everyone should start taking it at least 3 months prior to becoming pregnant.
And so does that count? So should women just start taking, like I've been on prenatal vitamins for years now. Like, does that count as your intake for that?
Most prenatal vitamins, not all, most should have the minimum that's recommended. Okay. And so that's something that's important to look at on a prenatal vitamin or even a multivitamin. Most multivitamins have it too. It's just checking the amount, and the amount is different for everybody. The base is a certain amount. And then if you've had a prior child with issues, you might need a higher amount. Okay. So it can change for people, but that base amount of folic acid should be in most all, if not all, prenatal vitamins and multivitamins. But man, have you ever gone to the multivitamin or just the vitamin aisle at a grocery store?
Yes.
And read this?
Yes.
It's so stressful.
It's so stressful.
So much.
And before my before my egg retrievals, there's so many vitamins and supplements you're supposed to be having. And it gets so confusing because at the end of the day, you're like, I don't want to take 20 pills. Right. So you're looking at your prenatals and you're breaking down the percentages. But to your point, the folate, the folic, I mean, it goes over and over. You're just like, they should basically just sell you a bag of pills. Be like, this is everything you need for your body weight and your age and your IVF journey. Like, here you go. Because it's super confusing and stressful.
Very confusing. And the interesting thing with folate or folic acid, I'm going to say folic acid because it's the supplement that you would take, right? People think, okay, I'm going to start it when I find out I'm pregnant, which for people who don't undergo IVF, they might not find out they're pregnant until, 8, 10, 12 weeks. The whole point of folic acid is to be on board before the pregnancy and the first 10 weeks of the pregnancy because it's helping the neural tube development.
Okay.
And that's done by 10 to 12 weeks of the fetal life. So when people are like, I'll start taking it now, that's great, but it's literally not going to do anything extra for the benefit that you're supposed to receive it for.
That makes sense.
Right?
Yeah.
So it's like, how do we get the education out there to know when you're shopping for a prenatal, hey, make sure it has at least this much in it.
Right.
And I have heard at one point that there were birth control pills that were adding folic acid in them.
Interesting.
So that if you still end up getting pregnant, which is not the best for the birth control pill marketing, I guess, to say what you got pregnant
in
on.
In case you get pregnant, at least you have folic acid.
And some of the birth control pills actually are adding iron in them too, because anemia is so common in pregnancy. And every pregnant individual should be taking a low dose iron because anemia is so common. And so these birth control pills, it's like, yeah, we hope it works. But if it doesn't, hopefully you'll have the folic acid and iron on board, right? Which is just too much. And then the over-the-counter aspirin was spot on. Yes, it can help decrease risk of preeclampsia. Okay. So, okay, those questions were great. And actually, that got us into some topics. But you mentioned something too about kind of your journey with IVF and how you guys ended up there. Can you tell us a little bit about, when you guys were like, yeah, we're going to start a family, this is what we want to do, how you ended up getting into the route of going to see a reproductive endocrinologist?
Sure. It's a long story, so I'll try to keep it short. But I had turned 35. My husband and I never really wanted kids. We have 2 huge families. Everybody lives here in town, and there's just like little kids running around all the time, and we like the quiet. And so I turned 35.
And they have a really cute dog.
And we have a really cute dog. Like very busy. And so I thought before I decide at 35 that like I need to do this, like I want this in my life, I wanted to make sure I was tested, and I wanted to make sure there were no issues. Like I didn't want to decide like, okay, I need to have a baby, and then them say, I don't know, you're missing an ovary or a fallopian tube or, So I reached out to you and I asked for a gynecologist. I had been going to the same team up north for years, and I just thought it was time at my age to go to go somewhere else. And so you recommended a certain individual who's very well known here in town, and it was really life changing. So I went and I met with him, and he spent about an hour with me. It's the first doctor I've ever been to that actually sat me down and asked me questions about me, my husband, children, our families, my health, cancer in my family, and all those questions. And so I told him I wasn't sure if we wanted children, but before I made the decision, I wanted my checkup. So he did.
So I just got chills when you said that because I know this doctor and he's fantastic. Yeah. And I'm pretty sure he probably took you into an office before he took you into an exam room and spoke to you like this, because how vulnerable is it as a woman to go into an OBGYN or a gynecologist's office and be stark naked with a paper gown on, and that's how you first meet your doctor.
100%.
And this doctor doesn't do that. And it's just, he's fantastic.
He's fantastic. I remember you saying his name, and I remember thinking, oh my gosh, this is a man, right? Like, ew, right? So, but like I trusted you and I wanted the best. And so I did. And we spent an hour in his office before we went into the exam room. And he's so professional. He's been around and he's taught so many other, peers and colleagues. And so, he always has a woman in the room or an assistant in the room. And so you're always very comfortable, and his bedside manner is so wonderful. And so I did like my testing and my blood work, and he came back and said, your fallopian tubes look good. Your ovaries are well, everything looks really good for your age. And, do you have any other concerns? And I said, I want to get tested for the BRCA gene. And he's like, well, we spent an hour in my office, and you don't really, your mom, grandma, and you don't have any sisters. None of them have breast cancer. You have zero history. I said, I do. I have one like aunt on the father's side that had breast cancer.
Was she young when she was diagnosed?
She was 35. She had a double mastectomy, and she's fine, and she's living now. But she did not have the BRCA gene.
Okay.
And so, he was like, okay, well, I guess I'll help you get tested for it. And so he was a huge advocate. I had no idea what I was saying or doing. And back then, a bunch of the celebrities were getting tested, right? Mm-hmm. That was kind of like the thing of the summer. So, he said, yeah, I'll help you. It's, so I went through that process. It came back. I was negative for the BRCA gene, and I didn't know any better. So I was like, I'm negative, and I kind of moved on with my life. And so he had told me at the time, like, your blood makeup for whatever reason for breast cancer is actually high. And, I think the average woman just in the world is like a 13% chance of getting breast cancer in her lifetime. And that usually happens later in life, in your 60s and 70s. And so I think at that time I was at 38% of getting breast cancer, but it's kind of like a bell curve. And so I was like, okay, not a big deal. And he said, you will always get 6-month screenings, and you will go from an ultrasound and mammogram, and then 6 months later you'll get an MRI, and we'll follow you. And I said, great. Moved on.
So at this point though, you had never had a mammogram or any breast screening because 35. You were 35.
Yeah. I was so young. And so nothing ever. And, I would do my checks.
Yeah.
And so I moved on from him, and he sure enough got me into the labs and said, you need to go do your first MRI and mammogram, and let's do all of it. I did it. Everything was clear. 6 months later, we're in March of COVID of 2020. And I get a call from the lab and says, hey, it's been 6 months. And I'm like, I was just there. And they're like, no, it's been 6 months. You should come in. And thank goodness, unfortunately, so many people during COVID didn't go into their doctor appointments. People were scared, right? And
True.
My husband said, we have nothing else to do. You're young, you're healthy, like go in. And I thought, I'll never forget driving there, how silly this is. And so I drove in. And
that's a good point. Then that's why people don't do preventative care or screening, because they don't see the point in it. Because I'm young, I'm healthy. Why is this, doctor having me do all this stuff, right?
And then you're having to deal with the insurance and like the not bills that come in, and then the bills that come in, and it's so complicated. And you're like, I don't need this on top of like everything else, right, in your life. And so I was bored. And so my husband's like, go. And I'm like, fine. So I drive over there, I get my mammogram, and they wouldn't let you stay at that time because of COVID. So I came home, and the minute I got home, I got a text message that said, you need to come in for further screening. And I have really dense tissue. And so it kind of said that, you have super dense tissue, you need to come back in. So I turned around like 2 days later, went back in, did an ultrasound, and all of a sudden, like the specialist, the radiologist was in the room. And of course, my husband can't be there. Nobody can be there. And so the radiologist comes in and says, hey, there's two type of things we see. It's kind of like salt pellets. They're either all spread out through the breast, or they've come together and it's like a jagged little ball. And yours is like a jagged little ball, and it's inside your milk duct. Like you have no family really, right? Family history. You're negative for the BRCA gene. You're super young. You're 35. This probably isn't an issue, but we should biopsy. And so we literally, before I left, I signed up for a biopsy, went straight, got my MRI. That was clear. I went in like a week later to get biopsied. And long story short, I came back, and sure enough, it was stage 0 breast cancer. And I mean,
and no symptoms, no, nothing. And all the breast exams had been normal. Okay.
Normal.
Yeah.
And it's one of those things that, again, like the last 3 years of my life, I've learned so much just about the woman's body, about my body, there's so many things out there that we just don't have. Like, that's why these things are good. These podcasts are good. And like everything you're doing is so good, because you just need to retain this information, And I remember saying to my husband, what do you mean I have breast cancer? Like, what is stage 0? That's not a thing, right? So sure enough, it's pre-chemo, stage 0. And I'm fine and everything's good, but I got a lumpectomy. But through that process and through you referring me to my gynecologist, I mean, thank goodness, right? This all happened for a reason. And so at 36 years old, I was sitting in front of a huge team of doctors, my oncologist, my radiation, everything, and figuring out, what do we do? Where do we go from here? Do we do radiation? And so from those conversations kept coming up, baby, baby, baby.
Right.
If you want a baby, you need to do it now. This is the time, because you need to get on cancer treatment.
So how did you go from, because I'm just trying to like fathom, I mean, you took it all in, but I'm trying to like absorb, like it's so much to take in at one time. And you guys go from, we're not going to have kids, to we're going to think about the idea, to like, you need to decide now.
Yeah.
Like, how did you, because you work, your husband works, y'all travel, like, how did you have that conversation of like, we got to figure this out? Like, I don't know, like in the team, did you feel like the team, I often hear from people too, that there's so many different doctors involved, you don't know who's like guiding the ship. So like, how did that work?
I think we were super lucky. So I kept calling my gynecologist through it and giving him updates. The team of breast cancer doctors we went with, like, all knew each other, or basically kind of all in the same umbrella. We also did a bunch of, for the breast cancer surgeon, we did do multiple conversations with that. And to your point, it is super overwhelming, because doctors at the end of the day are just people too, right? And they're just trying to own their craft and own their niche. And so the first conversation I had, the first surgeon I spoke to said, if I were you, because I would want peace of mind, I'd get a double mastectomy. And I was a mess.
Wow.
And then the next surgeon, right, would be the complete opposite way. I wouldn't. So it's just trying to figure out what's best for you, what's best for your mental health.
Mm-hmm.
And mine was, I felt with stage 0, I have no history of it. I'm negative on the BRCA gene. I felt like we kind of got a get out of free jail card, like
Mm-hmm.
get out of jail free card. And the only reason I felt like we got to that point of figuring this all out is because we thought we might want a child. And so to me, it was kind of just like this meant to be. And I still wasn't like 110% gun ho, like we're doing this, but I was like, if we're going to do it, we should do it now. Cause I'm going to need to get on tamoxifen, which drains your whole body of estrogen. So it's hard to get pregnant.
So is that the plan after the pregnancy's over then?
Yes.
So this isn't kind of like you have a lumpectomy, you're done.
No.
Yeah.
No, it follows you forever. So, because of like Susan G. Komen and those organizations, and there's so much history with, the trials and breast cancer, and it's come so far that even with later stages, the whole thing is being preventative and catching it early, no matter what stage it is. And so tamoxifen is a medication they've had for, a few decades now. It's been very tested, and that's kind of, they put you on it. And then over time, it decreases your percent, whatever your percent is. So I have a 28% of getting breast cancer again. So I'm still, compared to that 13%, I'm super high of getting it again. And so their job is, how do we get it down? They put you on tamoxifen, and over time, it'll cut in half. So moving forward, I'll get to the point where I'm basically the average woman again. So that's their goal.
Yeah.
That's how we decided maybe we should have a baby.
Yeah.
We just didn't know how much more complicated it was going to get.
Yeah. And I think that people forget when people are pregnant that they're not just, I don't want to say dealing with a pregnancy. It's not that. They're not just going through a pregnancy. They have other medical problems still exist, right? And I think that when people ask what it is that I do or what a maternal fetal medicine doctor does, it's exactly that. It's the doctor for someone who's pregnant who has all other things going on, which is the large portion of our population, if you think about it. Because how many people do you know that have been pregnant and had not one complication, or they didn't go into it having high blood pressure or something, or the risk of cancer recurring, right? Like that has to kind of be something that you think about, because your percent is still higher.
I do. And I know during COVID, when I was going through all this, I was also reaching out to you, and I'll never forget you saying to me, you're at a high risk of getting breast cancer again, but we can still get you through a healthy pregnancy. The most important part is getting you through the first trimester. And then you were like, we can do chemo like second or third trimester. And I remember my mind just being blown that you guys can do that. And then that's something you guys have figured out. At the same time, like it also made a very heavy topic in my household of, you just have conversations with your significant other through these processes that, you never think you're going to have, that are very deep conversations, right? So for my husband and I, all of a sudden talking to you was, okay, like if I do get breast cancer again in my pregnancy, what do we do? There's so many scenarios and so many, I know I'm an adult, but there's such adult heavy conversations, right? And it's scary. And in the middle of COVID and trying you can't meet these doctors face to face without a mask. I wouldn't know if I walked by mine today on the street, nor would he know me. That stuff is just, it's so weird.
Very different. Yeah. And you bring up the point too, to where it's so important that just because someone's pregnant, it doesn't mean that their treatment has to stop for other things, particularly with cancer. And breast cancer is one of those that I think the beginning part is always the hardest, because it's like, wait, what? Like it just doesn't sink in, particularly young, healthy. And you did this preventatively in a way, prophylactically in a way. And then I know you thought about this too, like had you not, what would have happened? Right? Like what if I don't know what exact type it was, but like what if it was one that's fueled by estrogen and then you didn't know it?
Right. So it was.
And you get pregnant and then estrogen just all of a sudden you've got a mass in your breast, and now you have to have the surgeries, the chemo, and all these things that might need to happen during a pregnancy. And I commend you for doing all the things that you've done, because I have patients that have currently lumps in the breast and they won't seek help because they know what it is, because they have other things in a family history or whatever. And it's the fear of the unknown, but then becoming a true diagnosis and having to cross that bridge. Right.
Right.
And I'm so glad that, you also bring up the insurance part. It's such a hassle to deal with insurance, period. And then when you're trying to get things done, it frustrates me too, because you're young and I'm young and healthy, right? People put that label on individuals who are, having children, middle-aged young women, whatever. And they miss the point of, I still have something going on, so don't dismiss me, right? So mammograms typically start at the age of 40. So if you're having one before 40, usually your insurance is like, I'm not going to pay for that. And I've had to learn too that you can cash pay for things. And Breast Cancer Awareness Month is October. So they usually do free mammograms different places. And so it's so frustrating that we have to learn to advocate for the stuff that we pay for insurance that we pay for, to convince our insurance companies that we're worthy to have this done. So did you have to reach out for those purposes, or did you have someone helping you a little bit along the way?
So my gynecologist is the one that helped, of course. So he's the one that really coached me. When you get tested for the BRCA gene, they basically call you, and it's like a counseling session where they ask you all these questions about your family history and cancers and stuff. And so he really coached me through that whole process in hopes that not only was I willing to pay for it, but like you still have to get approved to get it done. Like you can't just walk off the street and say, I want to get tested for the BRCA gene. So that's crazy in itself, whether you can afford it or can't afford it. And so he was my biggest advocate through it, of helping me get that done. And it's to your point, and I talked to him about it after. I mean, he was flabbergasted, like he was just shocked, right? And I talked to him after about it, and I was 35, stage 0, estrogen, like it was estrogen, and it was type 2. So it was definitely growing. I mean, I would have found it probably pre my 40 exam, because it would have been a huge lump.
Right.
Like it was growing. Right.
Yeah.
And so they caught it before it left my milk duct. Like that stuff is really crazy and hard to take in.
Yeah.
Sure enough, once something like this happens to you, then you share your story and somebody's like, my sister at 35, my mom when she was 32. And then you start meeting all of these women under 40, under 40.
Yep.
And I'm like, this is crazy.
Absolutely.
Crazy how many women under 40 are getting breast cancer and how many aren't getting tested.
Exactly. A friend of mine from medical school diagnosed at the age of 30. Age of 30. And here's the part that's frustrating. A birth control pill was changed for her. And within a week or two, she felt like a lump. She called her gynecologist back and said, I know I just had my annual exam. Something's new and different. And they were like, you just had it. We're not going to see you. And she's like, listen, I need to have my breast imaged. And they refused. It sounded like, until she pushed and pushed and pushed. And then they finally did just an ultrasound because she was young as opposed to a mammogram. They started there. And she ended up going through the whole, multiple surgeries. It was on both breasts when they finally got her in to do all these things. And years later, she had kids because at 30, she had to decide what to do because everything was coming off. And they're like, you also need to have your ovaries out. Right. And those are decisions when people get diagnosed young. You might not be ready to have kids at whatever time you're diagnosed, right? You have to decide, what am I going to do? It's a lot of stuff. And it's frustrating that we have to advocate for that. And I love that you had someone that was helping with that, which is just huge.
Well, and it goes again to like doctors and specialists are just humans too.
Yeah.
And so we made sure for my husband and I, and like my personality, like you want a team that fits the way you think. And so some people which works for them, rather just get the double mastectomy, not think about it and move on, right? And then you have other people on that whole other side. And so for us was like, if we're going to have to build a team of doctors, like we're middle ground people, like some risk, right? We're kind of risk adverse, right? Like in between. And so what was great is I'll never forget, like, and I still have the same oncologist today, but then my radiation oncologist, we were going to do radiation. And I remember sitting in the room with my husband, and she was my age. And I said to her, what would you do? Stage 0, right? We went through the whole case, and she said, if we give you radiation, you won't be able to breastfeed, which at the time, like, I didn't care. I was like, whatever,
Yeah.
like, right? Like, let's do my health first. And she said, but we can't radiate the same breast again. So if you get it again, you have to move straight to mastectomy. And that kind of hit home for me. And the fact that she took me through future steps so I could take my choice now. Like, had she not said that, I would have done the radiation because I didn't care about the breastfeeding, right? But because she said, if you get it again in that breast and I'm 28% likely, right? There's a high risk, we'll have to go straight to mastectomy. She goes, we've caught it early enough that if we don't do radiation and you get it again in that breast, then we can radiate.
Yep.
And so having those doctors too that are advocating as if it's them going through the process, like finding those doctors it was super important for me. Like, that's what helped me through that process. And my gynecologist knowing all of them.
Yeah.
You know, like, that also made me feel really good.
And that's so huge to have anytime you're asking about a procedure or a process. What are the risks involved? And how would this look 5 years from now, 10 years from now? How does this change? And it's great that you had a provider that did that on their own without you even having to necessarily prompt them and ask those questions. But that's part of the consent process, right? Is like, what are the risks and benefits? So not just the risk right now, but what does that mean for me 2 years from now, 5 years from now? Because the journey doesn't end, you know, especially with kinds of cancer, specifically breast cancer. 1 in 8 women is going to get breast cancer in their lifetime. 1 in 8.
Right.
In the lifetime, right? So obviously it can increase as we get older, but we cannot let go of the younger population. There are 2 things that I thought about when you were talking a second ago. When you mentioned dense breasts, they had a new article come out about if a woman has dense breasts on a mammogram, the radiologist needs to inform them that they might not pick up a cancer. So I'm in the same, I have very dense breasts as well. And so the reports, sometimes they do these things called BIRADs, where they're describing the ultrasound, sometimes, or the mammogram, excuse me. And they'll give it a number. And sometimes they give it a number because they can't look at the imaging well enough to truly diagnose it. So it's kind of like, oh, dense breasts or something like that. It could be some fibroadenomatous changes, just like densities. But it could be a cancer that you can't see because densities on an imaging look more white and cancers can look more white,
100%.
right? So how do you truly differentiate between the two? So they're starting to release these recommendations saying that when you go in, if you have dense breasts, someone needs to explain to you as the patient, hey, your breasts are dense. We might not pick it up as well in someone who has less dense breasts. And then there should be a conversation, right? Okay, since they are dense, maybe we do an MRI. Maybe we do other imaging to help us diagnose this. And I'm hopeful that we're going to see a shift in more care because the person reading it is a radiologist whose face you'll never see, right? I do a lot of ultrasound reading. And so you could be in a dark room with the pictures, but you don't actually see the patient as far as imaging like that goes for mammograms. So it becomes, there's a disconnect, right? Like a doctor orders it, a different doctor reads it, they send it back to this doctor, but they aren't going to have the conversation about the density all the time. But I bet your doctor did and would have because densities are harder to see.
I completely agree. And, you know, it was the perfect storm because my breast surgeon at one point before my lumpectomy pulled up my imaging and literally had to zoom in such a crazy amount to show me like my speckled little salt pellets, right? And she looked right at me and she said, I don't know how they caught this. Wow. Like it was that hard. And like the only thing I can attribute it to is it was COVID. They were bored, right? Like he's in the back, like
zooming
like he's
again.
Like, oh, at least I have a patient today to look at. But it was a perfect storm for me because to your point, when she showed it to me, there were all those waves of like my breast density and it's all white.
Yeah.
And then like I could barely see the pellets and what they were talking about.
Yeah.
And she literally was like, you're super lucky. I don't know how he caught this.
Yeah. That's fantastic.
I know.
The other thing that's really interesting. So we talked earlier a little bit about Down syndrome screening in a pregnancy. And there's a test. I don't know if you remember what type you had done, but did they draw a blood test and they tell you the gender of the baby and do all that? Or did they do your Down syndrome screening type, different names for the listeners here? But when you did the in vitro fertilization, did they do screening then? Or do you remember?
Yes.
Yeah.
So what was interesting, because we chose, like when you go through IVF and you get your embryos, they become embryos, you can test or you can choose to pay extra and genetically test the embryos. And then from there, you choose, right, to implant the healthier ones. And so they did do that, right, amongst all kinds of other genetic testing. And so our embryo was good, but they still, my OBGYN still tested me.
Yes, she did, because she's fantastic.
So she was like, you have probably nothing to worry about because he's already been tested, but we're going to test you again. And so she tested us again through blood.
So this is such a great point. So what you had done with the reproductive endocrinology office, we call, of course, we abbreviate everything, PGT, pre-implantation genetic testing, PGT.
Okay.
And then they put a hyphen and then another letter after it sometimes. So you can have pre-implantation genetic testing, PGT-A, which usually is for aneuploidy screening, which is chromosomal screening, which is inclusive of Down syndrome screening. Then you can have other ones that test for specific genes. If you know in your family, you have something, right? Like, oh, we have this that runs in the family. I want a specific gene tested. So we sometimes use a blanket statement, PGT, for pre-implantation genetic testing. However, even if you had that done, you still should be offered when you become pregnant and the in vitro fertilization's been done and a fetus starts to grow and you're like, okay, now I'm graduating from my IVF doctor to my obstetrician gynecologist. They are still meant to offer every pregnant individual a blood test to screen for Down syndrome, because that PGT test is not 100%. It's not diagnostic. It's a screening test. The blood test that the OBGYN offers is also a screening test and a blood test, right? So it's important to make sure that your OBGYN is definitely offering you that, even if you already had it done.
That's a really good point.
And people forget. Yeah. And a lot of people don't. So she's a fantastic doctor. And I know that she always does everything right as far as the recommendations go, because she's on top of it, which is great. So, and that's what also part of this is to get information out on like the questions you should ask your provider. Because if you know that as a consumer, right, in the general world, you would ask someone you're buying something from, like, hey, tell me about this product, right? And this is your body, your pregnancy. Like, why not advocate for yourself and learn a little bit more along the way to make sure that the person that you're seeing and entrusting your life with and your baby's life with is on board with everything, right? So that brings me to the segue of this blood test that they do for the Down syndrome screening. We call it Down syndrome screening, but it tests for the 3 most common chromosomal abnormalities, one of which is Down syndrome, trisomy 21, right? It also can look at the gender of the fetus. And so a lot of patients don't know it's even testing for chromosomal issues. They just know it as the gender test.
Yes.
Right? And that's how you can kind of communicate with patients if you don't know what type of test they had done. Interesting story. So recently I had a test come back positive for everything. Everything it screened for was positive. And some of these tests screen for not just these 3. They'll screen for something called monosomy X and sometimes something called DeGeorge syndrome. It's these companies that send the test. They're starting to expand what they're screening for, but it's not as good at predicting those. Like sometimes it's as low as 20% positive predicted value. And that gets into statistics and it depends on the age of the patient, et cetera. But you want a test that's good, right? That like has a high positive predicted value. So that if I tell a patient the test came back positive, I can tell you with a certain percent certainty that the fetus does or does not have this. I can't tell you with 100% certainty, but it's at least above 90%. That's your goal, right? For a screening test. So if you had a blood test drawn and all these things come back positive, that's weird. Okay. Ultrasound looked good. I'm like, this is interesting. What I don't think patients know, and a lot of providers forget about too, is that you can have a test that's done for Down syndrome, this cell-free DNA screening. And if it shows up positive sometimes and everything looks normal in an ultrasound, it can be something going on with the patient themselves, not the fetus, the patient. Because you're drawing the patient's blood.
Right.
You're spinning it down and you're getting something called a fetal fraction. And so you're trying to see if you get enough of this fetal fraction. It's coming from cell-free DNA. So it's DNA that's almost like shared between mom and baby in a way. And you're working on getting a percent. Long explanation for this, but the point is, this patient that I had seen was being worked up for a breast mass. Wow. And the reason that her cell-free DNA came back positive for everything when the fetus most likely has no issues is because the mom most likely has breast cancer. And that's where we forget. It doesn't happen often that we see that, but she knew she already had a mass and she was being worked up. However, imagine young, healthy individual, the test comes back positive, everything else looks normal. You have to discuss the possibility of a false positive for the fetus. However, the mom could have something going on, like a rare cancer or some kind of disease.
Because to your point, you're pulling the blood from the mom.
Correct.
Yeah.
Right. And those are the things that I would say 95+% of my patients that I see on a daily basis, when I ask them if they had any type of screening for Down syndrome or chromosomal issues, they have no idea. And then I find out they've been sent from their obstetrician gynecologist office, but no one did any counseling before they sent the blood work. So they don't even know what the blood work was sent for. They're just like, yeah, they took like 10 tubes of blood. So that's a big thing that I love the teams you had because everyone seemed to be talking to you. Plus, I'm sure you had good questions for them to maybe ask. And I think that's part of what this is too, is trying to find out, I'm not going to be an annoying patient if I ask questions to my provider. And I think we fear that.
Yes.
You know, like to go in and have your list on your phone. But if you don't have the list, you're going to forget maybe.
Yeah. And I think it's important that you have to get comfortable with when they are in the room. That's the time to ask all those questions. So I went in with all my questions and, you know, my OBGYN's like, I'm yours. When I'm in this room, I'm yours. Like I'll stay as long as you need. And so it's, I feel like medicine is changing, especially in the breast cancer, the oncology, the IVF, you know, the OBGYNs, where it is more about the patient because we should be asking all these questions because we're all individuals and we're all different.
Yeah.
You know, somebody can go through IVF and have like the best experience and they get pregnant and they move on and they get pregnant again and they move on. Right. And then there's like the rest of us.
Yeah.
Where it's like a detective case and you know, you have stuff all over the wall trying to solve a mystery.
It's like a detective case. It's actually really good.
It is.
I think that's a good example of that. So I want to kind of go into a little bit of some of the things that I have because there's this thing called an advocate assistant that I've put together and people can get it for free on the website. If you even just go directly to the link, it's drlexihill.com/advocate. And you can get this handout. It's 13 questions to ask your OB provider. And I'm going to give this example here to Jami so she can kind of see. But that's for like all comers. That's for anybody and everybody who goes to see their OBGYN and they just want to know some basic questions kind of in order. Like at your first visit, then what are some questions everybody needs to ask? And then what are some questions you need to ask when you get closer to delivery? And you can put them on your phone or whatever. But I think that these are questions that your provider should probably be addressing with you anyway. But they are kind of overall questions. And do you think that you had a great team, but if you were like, I don't know where to start, is this something that you think would be like, oh, these are helpful questions? I want them to be phrased in a way where anyone's OB provider doesn't feel like someone else is trying to take their place or anything, but just the way to ask a question, right? Like, how do you open it up to get an answer back as opposed to being deflected, right?
Yeah, no, I think it is. And this is something like I would have used anyway, because I was moving from, you know, the breast cancer team to my IVF team to then all of a sudden I'm in an OBGYN, right? Like I'm going through all these phases. And so you're like, your focus is changing as you move through these phases of your life. And so like, for example, even, you know, can we discuss my options for Down syndrome screening? Like to your point, I think women and their partners get worried about, you know, what that means. And a lot of them say like, you know, I think people just, they get, unless you've gone through IVF where you have to be super open and like prodded and tested and right, and you just say yes to everything, you know, you have a lot of other people that fortunately get to have the natural, you know, oh my gosh, we're pregnant and oh my gosh. And those people need these questions just as much as like we do coming from like the IVF world,
right?
Like the normal person who's getting pregnant, like needs these questions.
Yeah. And having the ability to decline a test is fine too.
Yes.
But not being offered a test, that's just not the way it should go. Yes. You shouldn't get to where you're seeing me as a high risk doctor and no one's asked you the basic questions or done your diabetes screening or, you know, done any ultrasound yet, or you don't even know your due date. And now you're in the third trimester. That's frustrating to me because there are layers of medicine, right? And so I feel like at the base is your OB provider, whether they're a nurse practitioner or an OBGYN or a nurse midwife, whatever level they're at. If they're caring for your pregnancy, these are some of the basic questions, for them.
Absolutely.
And then for that too, for the advocate assistant, we have one for IVF. We have one for advanced maternal age. So these are kind of things that
I check all the boxes. So can I just get one on one page?
I know that's the thing, right? You can pick as many modules as you like and just build your own high risk pregnancy, right? It's just the fun part. But these have little check boxes on them. They have places for notes. It's just a way to kind of help roll through everything a little bit to guide your pregnancy if you have any of these little high risk issues along the way. And then you'll also find on there what I call these little flow sheets to talk about what are the risks that you have and then how you tackle those risks. So because in the very beginning, we started with the question about antenatal testing and fetal well-being testing, I wanted to talk about your scenario. So you had IVF, and then how old are you now? Do you mind me asking?
38.
38. So you know that advanced maternal age is 35 and above.
Yes.
So because we had done some coaching before on that. And you've also had IVF. So those are two instances where the risk of stillbirth increases in the third trimester. And stillbirth just means the baby passes away. I like to tell people it's for no reason, that we can't always find a reason, but for some reason the baby passes away. So there are certain high risk conditions that we as providers for pregnancy recommend antenatal testing or fetal well-being testing. And I always like to tell people the first time I meet them, hey, when you get to whatever gestational age, you're going to start seeing me on a weekly basis because we have to do this fetal monitoring or fetal well-being testing. Because it's no fun to go through the pregnancy and then you get to, let's say, 36 weeks and they're like, okay, we'll see you every week, or 32 weeks, we'll see you every week. And you're like, well, why? So that's a conversation on these advocate assistant handouts to have with your provider. So even if you currently aren't high risk and you might become high risk later for some reason, or you're entering this high risk, IVF in and of itself is now recommended to start fetal well-being monitoring at 36 weeks. That's a new recommendation in the last couple of years.
Oh, wow.
Yeah. So there's that. And then the age debate is all over the place, right? Like, if you're between 35 and 39, the risk is smaller than if you're between 40 and 50. And then if you're 50, the risk is even higher. So it's on a continuum, right? It's not just like any age above 35 is going to be the same risk. It changes. And it's higher for people if it's their first pregnancy, right? And so there's all these little risks mixed in. And so my question then would be, this fetal monitoring, if no one has told you about it, do you have any idea how would someone try to monitor a fetus for well-being? What would you think? What could you do? Or what would they do?
Yeah. I will be doing that. So, let's see. So I'm like, there's so many moving pieces.
So many. Yeah. It's very hard. So anything I think to help someone keep it straight is always fantastic. So for the fetal monitoring part, when you get to do it, sometimes they do it once a week. Sometimes they do it twice a week.
Okay.
Sometimes they put these two belts around you and sometimes they do an ultrasound.
So are they measuring your belly? Is that okay?
No. Yeah. They're putting one belt that goes where the heart rate is. So they'll find the baby's heart rate and put the belt down there. Then the higher belt goes on the top part of your uterus. And it actually is to try to see if it picks up any contractions of your uterus. So there's two monitors. One's for the baby's heart rate and one's for the uterus. We call it a tachometer. It's trying to see if there's any contractions of the uterus. So that's one way to look at it. And we call it a non-stress test. We just call it an NST because we want to abbreviate everything, right? And you can do that, or they do an ultrasound where they check for 4 things. And the ultrasound we call a biophysical profile. We just call it a BPP. So you'll start hearing your doctor probably going, oh, you're going to get scheduled for NSTs, BPPs. And you're like, can you please tell me what that is, right? And the biophysical profile, they look for practice breathing, for the baby's diaphragm moving. They look for movements overall of any part of the body, muscle tone, like a flexion and extension of a part of the body, and then the amniotic fluid. So they look at those 4 things.
And they do that every week.
If that's the method they choose, yeah. And then if they add the non-stress test in, that's a 5th part of a full biophysical profile, which includes all 5 of the things. And then you can do a modified biophysical profile where you do the NST, where they put the belts on you, and then an amniotic fluid level. And those 2 things together are considered a modified biophysical profile.
So for your patients that are coming to you, are you the one doing those?
I'm reading them.
You're reading them.
So someone on the site, since I'm doing telemedicine in whatever city or state I'm looking at that day, they're doing that boots on the ground and I'm looking at it on the other side.
Got it.
Yeah.
Okay.
Yeah. So yeah, it's kind of fun. So, okay. I think we're hitting almost like we've done a good job here. We've gone for a while. I guess what I would like to close up with, first off, the way that I kind of try to think about this in talking with people is my little concept of my fun little 3 dots on my coffee mug here. It's expanding knowledge. So I think that we talked a lot about information behind pregnancy, about IVF, about breast cancer. The D is developing skills. I think we got really nice into how to ask questions, things that you could, kind of encounter along the way that you need to advocate for yourself a bit more. And then the I is the impact. And that's the whole point of doing this too, is to have some type of, I have trouble choosing another word other than impact, right? But having some kind of effect, basically like a strong effect on someone, or the ability to have someone else hear this story or hear a little bit of what we're talking about and say, that resonates with me. Mm-hmm. So do you have anything that you would either, number one, like to share, number two, resources, questions, anything else that you could say, hey, I wish I would have, or here are things that I still do that I can do to advocate for myself in my pregnancy?
Yeah, I think the first thing is it starts with stuff like this, right? Being very fortunate with our last embryo transfer, the last embryo we had to finally get pregnant. So I've made it a commitment to be really open about my story and not forget what it felt like in the moment. So I think it's really hard and it's really natural as human beings. When I was going through IVF, it was over a 2-year process, 2.5-year process. And I would ask other women that went through IVF and they're like, oh, butt shots, not a big deal. When I tell you that the breast cancer was nothing compared to the IVF, like I would take the breast cancer back at stage 0 than like the actual process, because my IVF road was by far the hardest thing I've ever done. It was the most gut-wrenching. I've never cried so much in my life. It was awful. The whole thing was awful. And so I feel like nobody was honest with me about it, because I feel like once you have the baby and you get the baby, or it doesn't work for you and you move on, you just black out, right? Because there's so much PTSD from it. And like, I refuse to be that person. And so I've worked really hard to get here. And so it's my goal to make sure when people do reach out and ask that I am honest. Like, I'm still not through it, right? Like we still have all these tests and all these risks and getting to, term.
Yeah.
Getting to term.
Getting to term. That's right.
There's so much still ahead of us. But I think it's really important that like anybody listening, like I would just search the web, for IVF, on Instagram or anything. And that's why it's so good for what you're doing. Cause I didn't have a home outside of my team of doctors to hear other people like this on a podcast talk about it and be completely open. You open a People magazine and they'll say, so-and-so went through IVF, and I will get so excited and I read it and it's one sentence. She went through IVF and they're pregnant. I'm like, it doesn't work that way.
Yeah.
It does for some IVF patients, but for the rest of us, like I had surgeries, like I had procedures. We had extra screening. It wasn't taking. They didn't know why it wasn't taking. Like you have to dig so deep into this. And so that's kind of the impact I want to leave with my story is I don't want to forget how hard it was.
Yeah.
How much I hated it.
Yeah.
Well,
because it's good for people to get the honest truth from someone, right?
Yeah.
Yeah.
Yeah. And, I'm not out the other end yet where I'm completely healed. My husband and I have been pretty quiet, tight-lipped. We've ran into you a couple times and I didn't tell you I was pregnant. We've been, I'm 21 weeks now and we're slowly, my baby shower the invitations are in the mail. And I'm like, some of those people that's how they're going to learn I'm pregnant. I'm kind of frozen with it. And although we're in the moment and we're enjoying the little things and he's moving now and you just carry this baggage, right? Yeah. And I think it's normal and I think it's healthy to talk about. And again, like to come full circle, that's like why this stuff is so important, to be able to have a place to help with questions, to listen to a podcast. And so like what you're doing, I think is fantastic.
Thank you. Thank you for coming today and sharing your story. And just, I agree. Everything is going to be so big with regard to learning other people's stories so that you can relate and understand a little bit more and educate yourself while you're surfing the web and trying to just find places when you're at home by yourself where you can feel comfortable learning more and even asking questions anytime, which is great. Thank you
you
so
should do a
much.
whole thing on endometriosis.
Endometriosis.
My whole surgery I got to go through.
Okay.
So at some point you have to do a whole topic on that.
You know what I think we'll do? I think we'll get this wonderful gynecologist that we're talking about to come on board.
I think so too.
I do know he has retired recently from part of a private practice, and I think is still educating young minds. He's very involved with residents and teaching, and is just absolutely fantastic. So maybe that'll be on my list.
Well, we haven't let him know we're pregnant, so you should probably let him know.
Okay. I have to do that. I'll have to do that. Well, thank you guys for listening and or watching today, whichever you're doing. You can always go to drlexihill.com for more information. The sheet we were talking about today for the advocacy, the 13 questions you can ask your OB provider, you can find those at drlexihill.com/advocate. And then also what Jami was talking about today some too is if you have questions and you want to try to book a consult with me, I am licensed in X number of states. I say X number because it seems to change every month depending upon the licensures that come in and all that kind of stuff. But you can go on the website and you can easily navigate it and find out where you can go on the website to then have a visit with me if you would like. So again, drlexihill.com, and you can check that out. Don't forget, subscribe to the YouTube if you can. It's at Dr. Lexi Hill. If you see a theme here, everything's basically Dr. Lexi Hill. So you can find that on social media, on Instagram, on Twitter, on LinkedIn as well, if you're into that. LinkedIn does have a little bit more information for the doctors that are taking board exams, since I end up working with them as well. So I'm kind of spread out all over the place. But I hope that you enjoyed the podcast today. I hope that you enjoyed learning more about everything with regard to IVF and some about breast cancer, and visiting with our guest today, Jami. And we will see you guys later. I'm Dr. Lexi, wishing you a happy and healthy pregnancy.